Call the member for Bowman.
Thank you, Deputy Chair. And the holy grail of an electronic health record is something that most developed economies are working towards. And in summing up this side of the debate, I just wanted to make the observation that this nation will have an electronic health record. It's going to happen. There is a graveyard of good intentions in other developed economies, and they are lessons from which we can learn. Minister will be aware that there has been enormous expenditures in the UK and in the US, and to go down exactly the same path and make the same mistakes is what makes this side of the chamber so determined to ask the right questions about the electronic health records. Now, the contributions to this debate have been effectively divided in two. One is the significant upside of having a functional electronic health record, and look, there is no doubt about that. There is no doubt that we can see great savings and potential to the idea of having electronic information transmissible between the people who need to know. That's a no-brainer. And we know on the other side as well that there are significant concerns about privacy that have to be met. And if I can distill it into a single sentence, we need to make sure that we move this project forward at the speed with which current technology allows. Now, I don't want this to be something in between pink bats and the NBN, but we have genuine experience from around the world that there is every possibility that that can occur. So today's debate really should be about how do we prevent that occurring? How do we work carefully? How do we focus in the areas where gains can be made undoubtedly? And how do we acknowledge the areas where we're effectively doing little more than tipping money into some omnivorous money-eating machine that is a concept developed and controlled by public servants, from which politicians have effectively abrogated their responsibility in the hands of fractured and separated private providers who accept contracts not knowing if they can deliver, at risk of forfeiting, at risk of going broke and at risk of not delivering. Now, that's not made up. That is direct quotes from what happened in the NHS. We can learn from that, but we don't if we have blind contributions in this chamber that focus on nothing but the upside of an electronic health record. Now, let me speak for a moment as a clinician and as someone who developed Australia's first mobile ophthalmic database for clinicians called Red Ant, and I programmed it with Masood Mahmood in Darwin in 1998. And the intention was, on a small laptop, to have every electronic image of a retina taken in Indigenous Northern Territory available to any clinician who visits, and by simply coming home and plugging in the laptop, one simply uploads the most recent clinical information by matching a patient identifier that was generated temporarily and superimposing it by using the common personal details. The concept was good. And the idea was that a remote ophthalmologist or optometrist looking in the eye didn't panic on an investigation, not have available the latest information, and then effectively send that Aboriginal Australian on a 700-kilometre bus or four-wheel drive trip only to see a doctor and be told you're okay and you didn't need to come in. There are massive health savings that can be generated through reducing the false negatives. The ability of a clinician to look at a patient in the eye and say, you will be okay and you don't need to come back and see me for 12 months. That's where the massive savings exist in the health system. It's not, as commonly believed, becoming 1.5% better at diagnosing cancer, because those people will represent with symptoms and be picked up often within days or weeks. But the true costs in the health system are false negatives. The true cost is the ability of a clinician to move to the top of their licence and make a call you don't need any more resources spent on you for a period of time, and that clinician is right. What you can't afford is continual investigation of a person who's fundamentally healthy, and the electronic health record offers us some aid in that area. But look, let's not fool ourselves. Hummelstein from Harvard, Wharton, publications in the Wall Street Journal have all shown that there actually is no evidence that this will save money. Conceptually, we can see that it may, but in reality, we haven't yet proven that this electronic health record even improves the patient experience. Okay? We may be able to get rid of some paperwork, but there is no evidence that for small providers, they can actually recoup the cost of setting up an electronic health record system. Sure, Kaiser Permanente will have excellent stories about working in-house on an electronic health record and how much that saves them. But we are dealing with an incredibly fractured and heterogeneous health system in developed economies like Australia. So, Deputy Speaker, we all know that the world is shifting towards using electronic transmission of data. I mean, we do it when we go to the shopping centre, we do it when we go to virtually any sector where we spend money, but health remains an area where we're incredibly cautious. But at the same time, what we have within the health system are young providers, doctors, nurses, midwives, allied health workers who know no other way except using an iPad. They can't even navigate their way around a hospital without having access to electronic information from pathology and radiology. So as I said when I began this address, it's going to happen. The only debate in here is how we sequence the work. Do we focus in the areas that we can really make a difference? And I put to you, we're the only nation in the world where we know of the 3.6 million Australians who have an enhanced primary care chronic disease record at the moment that is run through their local GP. That's right, we are the only country that has captured the 3.5 million Australians who have the most to benefit by having an electronic health record, transmission and portability of that information. That's where we should be starting. So my grave concern is in the $72 million investment into Wave 2 trials, because there is no guarantee that that money spent will feed into an electronic health record. No, we're not learning lessons from overseas, Minister. We're actually just starting again with our own series of pilot trials. I've visited them. They're incredibly impressive. But at $8 to $12 million each, I'd want to know that the few hundred people going through the Mater Hospital program in Brisbane is actually going to lead to a more efficient information transmission system than what we have currently. And I need to know that that money invested isn't a wasted cost, but one that actually leads towards an electronic health record. And I know the Minister will be just as concerned as I that the clinical leads group that is meant to be providing the clinical oversight of this process has had their meeting delayed again for another month. So I would hope that the Minister will have good news to give to them when they finally meet, because I tell you what, the great fear with Australia's electronic health record is that this falls into the hands of unaccountable bureaucrats, and it's the clinicians and effectively the politicians who need to remain responsible who lose control of the process. This is not a fairy tale, Deputy Speaker. This is the story of distressed NHS providers, distressed contractors, CSC, Fujitsu, Accenture, you name them, all coming away after 6 years, after billions of pounds spent, unable to even provide an electronic health record to the southern half of the UK. I mean, this is potentially the greatest IT disaster the world has known in the UK NHS. And I simply make the observation, what have we learnt? So today is not a debate about whether we think a health record is a great idea. It's probably worthy to ventilate the issues of privacy. It's probably worthy of ventilating some of the issues that will recruit clinicians to get involved. But let me just say, this is about identifying how to sequence and stage the process. I don't see any evidence of that, Deputy Speaker. I see groups working in a well-meaning way to develop a health record, uninformed by what's happened overseas, with no accountability back to this place, with minimal reporting, with little understanding of where we're going next. No idea where we're going next. And we just had to look at the Australian yesterday to see that as long as you feed the machine, they will keep coming up with ways to spend the money. But for the Minister, I want to see not the holy grail of a health record. I'd like to see this Minister just step by step get this process moving forward, because we are a nation blessed with a massive Medicare database and PBS database. We are able to start having organisational and provider identifiers. I mean, that's not the hard part. But ultimately, we need to ask the question, is it the be-all and end-all? Because I'm putting to you that providers will only ever be able to put so much health information on electronic record. For a long time, we will need something else. I mean, if you compare a technical manual to a novel, there will always be some information that is extremely difficult to capture on a health record. So we may have to be doing more than one thing at the same time for a significant period until this health record is up to scratch. We also have the massive concern that the EU is aware of, which is that data even now being collected can't be effectively archived and will be time limited. Are we using the XML formats that Sweden, for instance, have moved into to make sure that that archiving can guarantee that information collected today, last year or 10 years ago is still accessible next year, that we don't simply have an upgrade problem where we lose data? So I don't come here to give you a shopping list of concerns. I simply want reassurance that this government is not telling me it's all okay, because the lesson from the US in that Keynesian 2008 exuberance where hundreds of, well, effectively billions of US dollars were committed to encouraging GPs to develop an electronic health record, and you had the Americans, of all people, the Americans saying, slow this down. Let's learn from the UK. Let's see what is going wrong. This is potentially a 10 to 15 to 20-year timetable, and I would hate anyone to think this has to be a deliverable by 2014, because it is going to be way more complex than that. Now, this wouldn't mean much, this contribution today. This would just be another 15 minutes wasted in the chamber if we didn't have the grief and the disaster of what has been referred to in the UK as Labor's greatest IT blunder. This is not small bickies. This is, Deputy Speaker, $15 billion budget announced as early as 2004, which effectively gave us nothing but confusion. In fact, many, and I see the shadow spokesperson here, many member for Boothby will say that it cost lives, that it cost heart attacks. It actually did harm. Now, of course, I could never say an intervention won't have some harm, but I do recall what is the prime belief in medicine. And I hear someone saying it in Latin to me, translated across the table, primum non nocere. We should not do anything that hurts people, okay? And the best way to do that is to stage it, to sequence it, to focus on those that need it most, and not regard this as something that's going to happen overnight. We cannot afford to be investing in entities or providers who cannot deliver, and we have to have the strongest of assurances that they can achieve it. And the first sign that I see of slippage is when those contracts go from $1.5 to $3.2 million, or $48 million to $52.5, or where individuals who are contracted to do something suddenly end up doing something else. Or, in the worst case scenario in the UK, they start suing the government, okay? Or politicians start writing to the Secretary of the NHS saying, I warn you not to sign that contract 9 months before it ends in tears. We just don't want to go there. And I don't want to be the professor of doom here, but the minister needs to, in her first few weeks in this portfolio, needs to take a very, very strong interest in what I warn can be, you know, the next NBN. I mean, this could be a genuinely government-imposed, extraordinarily expensive solution that simply leaves us where the UK is. Now, I'm not saying that we're smarter than the UK. I mean, I would like to actually learn from the UK. I'd like to know that there's been some lessons learned from an economy that devoted an enormous amount of money to this proposition. And if you leave it to providers to develop this, to do it in open source code so that everyone contribute to the improvement of the system, that might be fine. But where we head off in proprietary systems that are fundamentally secret, that no one has access to, and that if the company goes bust we lose completely, then that's got to be a concern. And I have a fear that that could well be happening here in Australia. So I welcome the minister's intervention, which is please, don't continue. I know it can be uncomfortable to hear, but the great challenge is, Minister, that many of the speeches that we've heard from your side of Parliament could simply be lifted out of the UK House of Commons. You could have just lifted it out of the UK House of Commons, which was Labor MPs, Deputy Speaker, speaking blindly and blithely about the importance of an electronic health record just months before the whole thing collapses. And that is the only warning that I give you. On behalf of a clinician, we'd love to have it working. On behalf of a clinician, we don't see why there can't be some better access to item numbers both through Medicare and PBS for public providers who are looking after the health of Australians. There's lots of easy gains. There's lots of easy wins. But it's not going to happen if we have the continued delays that we have seen from this government. And you should know, Minister, about the cancelled meeting for lead clinicians. You should know about that. So, what is happening and why can't they meet? What are they dealing with? This, in the summing up of this debate, is probably your chance early in your portfolio to tell us exactly where things are at, exactly where the hiccups are, who was given the wrong specifications, what was provided back to the department that in the end couldn't be used. Okay, why are we delaying meetings with clinicians? This should be the first group you meet with, not the last. They are simple questions that I put to the minister, and I emphasise that the support for the concept of an electronic health record is on both sides of the chamber. But I would love to see more concern about where the project is heading overall. It is large, it's complex, it's expensive, and it is, as I said earlier, there is a graveyard of well-intended but ultimately misguided attempts to develop this record. It will take collaboration. It will take time. Start small, do it slowly, sequence it right, and we may be able to go where other nations have failed.
I thank the honourable member for his contribution.